Welcome, Dr. Prasad. Prasad Sabot, आप सर muted है sir.
Good afternoon, everybody.
Good afternoon, Prashant.
Hello, Dr. Prashant Sabot.
Very nice, very nice.
Yeah.
Good afternoon, Prashant ji. Good afternoon.
Yes, Hare madam.
All the best to Yash and Amit. So
Yeah.
you look a little worried, so don't be worried. So we are all going to just discuss the cases and the
Friendly, we are
paper,
very
yeah.
friendly
Just be
mentors.
relaxed. Yeah.
Yes.
They had their rehearsal, so they know how it is.
Yes.
Tell
Ma'am,
me,
shall
problem.
we begin? Shall we begin?
Yeah. Please, sir
Doctor.
says
Yeah.
he's there.
Right. Okay. So
Sir,
we
आ
will.
गए, yeah.
afternoon, madam.
Very good afternoon,
Hello.
sir.
Very good
Yeah.
afternoon, sir. Very good
Good
afternoon
afternoon,
to you.
MK Nair sir. Good afternoon.
Good afternoon, sir.
Good afternoon, sir.
Good afternoon, sir.
चलिए यश start करें आप.
So we will. No, ma'am. First, Dr. Amit Vashisht will start.
Yeah, Dr. Amit
Yes,
will
ma'am.
start.
So Dr. Amit Vashisht is a PG resident of the MS Ramaiah Medical College of Bangalore, and he would be making a case presentation of rethinking asthma in adolescents more than just inhalers. So something very interesting, and let us have a listen and a watch to what Amit is about to present. Amit, start sharing, please.
Yeah, before Amit, 1 minute, Amit.
Yes.
Once again, thanks for this opportunity. Respected sir is there, past Vice Chancellor of MKC Nair, father of adolescent medicine. Welcome, sir, and I respect my grateful to Dr. Shushma Desai, Dr. Hima Bindu, Dr. Geeta Patel, Dr. Shamik, and Dr. Manmeet, and all the speakers, and other one more boy is there who has come, Prajesh, I think is presenting. And Dr. Amit has managed this case actually. He is the one who picked up a lot of the comorbidities in the condition. I thought in this the forum to start with, and without taking much time. Once again, thanks. It's one of the unique opportunity and unique scientific program going on. And for kudos to the team. And I request Amit to start with the program.
We welcome. I take this opportunity to thank both the mentors, especially my very dear friend Dr. Somasekhar ji, to be a part of this program, and dear Dr. Mamta ji, who had consented to be a part of it. Both the mentors are excellent. The presentation itself are they speak volumes about them, and I am thankful to Dr. Amit and Dr. Yash. Both of them are very enthusiastic PGs. So let us have a look at what.
Thank you, ma'am.
Thank you, ma'am. Thank you, sir, for the kind words. Is my screen visible?
Yeah,
Yes,
visible.
it is.
Make it big.
Yeah. Thank you.
Good afternoon, everyone. I'm extremely grateful for providing me this opportunity to my mentor, especially Dr. Somsekhar sir, and all the esteemed and august senior doctors present here today at this forum. I'll be beginning my today's case presentation. The title of my case presentation for today is Rethinking Asthma in Adolescents Beyond Just Inhalers. My name is Dr. Amit Vashisht. I'm a pediatric resident from Ramaiah Medical College, Bengaluru. My mentor is Dr. Somsekhar AR sir. He is former HOD and Professor of Pediatrics, Ramaiah Medical College, Bengaluru. He is also Chairperson-elect of IAP ECHC 2026 chapter and Chairperson IAP State Allergy chapter. Today I'll be presenting about a common case which we quite often see in our OPDs and also in our wards. Coming to the case, we have here a 15-year-old female patient who is currently studying in the 10th standard. She hails from Bengaluru rural. She was admitted to our wards on the 11th of March 2026, and we examined her on the same day. And the informant is the mother, who is reliable. Coming to the chief complaints, she came to us with complaints of cough since 1 week, complaint of breathing difficulty since 1 week, and complaint of chest tightness since 1 week. Here we have a 15-year-old female child who is a known case of asthma, was apparently all right 1 week ago when she developed cough, which was insidious in onset, gradually progressive, predominantly dry in nature, and associated with scanty mucoid expectoration more during the night and early morning. It was also associated with breathlessness, initially on exertion, but now even with routine activities. The cough was also associated with wheezing, intermittent in nature, more during the night and after exposure to triggers like dust and pollen.
Dr. Amit, we'll just take one word. Here you are said straight away because it's a known case of asthma. Why you say it is known case of asthma? One thing. Second thing is here in this history of patient, particularly in this slide, anything is contributing to your history or your diagnosis?
Yes, sir. Sir, she's had repeated episodes of cough, breathing difficulty, and chest tightness, sir, and especially with scanty or dry mucoid expectoration more during the night, sir, more nocturnal in nature. And it's also
So
associated with
nocturnal in
wheeze,
nature goes usually in favor of obstructive airway disease. Okay, fine. Okay, fine then.
Yes, sir. Also associated with wheeze, sir, especially after exposure to triggers like dust and pollen.
So one more point towards your diagnosis is triggering towards or exacerbation after the exercise. One more is there. You
Yes.
have mentioned, and as
Yes,
well
sir.
as triggers like dust and pollen. Fine.
I think what sir is trying to say is don't commit as asthma straight away.
Yes.
That leaves
Correct.
out all other differential diagnoses.
Yes, sir.
It could be a foreign body. Why do you say
True,
it's not a foreign body? It could be anything.
Yes.
So
Sir.
when you present what is the symptoms, why the symptoms, put it all together. In the end, we have a differential diagnosis, which each one you will say which is what. Why am I saying this one? That would be a better approach. Sir is absolutely right on
Yes.
that.
Noted, sir. I will do so. Patient also complained of chest tightness since 1 week. She described it as a constricting sensation over the chest, intermittent in nature, and it worsened especially during the periods of cough and breathlessness, and it was relieved partially with use of inhalers. She's also had history of 3 similar episodes in the past, which are suggestive of exacerbations, which are often relieved by nebulization and inhalers.
What is this?
Also,
in
the
this
patient
case,
gives
especially
history of...
go back.
Yes, sir.
In this, what is that important thing is giving you message that it is a case of obstructive airway disease?
Usually, it is relieved with the inhaler
In
or
adolescent,
nebulization.
rather than cough is breathlessness, in the adolescent, they come with chest tightness. That is one thing. What is the other important thing here giving a message?
Also, with the use of inhaler, she starts doing better, sir, with nebulizations.
Response to the medications. Response to the medications tells there is a obstruction that is responsive. Fine.
Also, the child gives a history of recurrent itchy skin lesions since early childhood, involving primarily the extensor areas. And also, she gives history of watering of eyes, excessive sneezing, which is always recurrent, more during the winters since last 3 years. Also, she's had history of breathing difficulty while playing Coco at school, which she usually doesn't get. Also, recently, there's a shift of residents to a place near an incense stick factory, which had a lot of pollutants. And also, she has a peculiar habit of sniffing nail polish once or twice a day since the last 6 months. And she's had no history of fever, no history of wet cough, no history of hemoptysis, no history of night sweats, or any contact with any TB patient, no history of regurgitation, no history of a loss of appetite.
Amit, please concentrate on this slide. 1 minute, go back. Please tell me about
sir.
you are told so many factors. Each one, can you explain history of itchy skin?
Yeah, it points towards most likely atopic dermatitis, sir, which is often associated with kids with asthma, and also with allergic rhinitis, since she has a history of watering of eyes and excessive sneezing as well. We find a lot of kids having both.
See, two things here. One is that she has got atopic dermatitis as well as allergic rhinitis. These two will become predisposing factors also. And rhinitis can be taken as comorbid condition. That's why we call it as treat the sneeze, then only wheeze will be controlled. So these two are very important markers. And that's why this case it has come to you because something has not worked out properly. That's why she is coming with recurrent cough, wheeze, breathlessness. And another thing is history of having one more. Just read that.
History of having breathing difficulty while playing Coco at school, sir.
What is it suggestive of?
Yeah, exercise-induced asthma.
Very good. How many, what is the percentage of, especially in adolescent, what is the percent of excess-induced asthma? They'll come with on crying, on laughing, they'll get the exacerbation.
Yeah, we notice it to be around 25 to 30%, sir.
Yeah, but if you take the Indian population, the data says around 8 to 10%. That is how the statistics are. Because we had to treat this excess-induced asthma. Can you just
Yes.
out of the way, we'll not go to that. Can we stop it? Can we stop the exercise? We'll ask her to not to go further because it is giving.
No, sir. We actually have to promote exercise.
Okay, we'll go. We'll talk about that. Okay, then
We suggest pre-warm-up exercises, sir.
we'll go to that later once you go to management. Then
Yes. See, also
history
there's
of-
a history of change of residence, sir, near incense stick factory around 6 months ago.
she is from a state and a Pune area where they got this incense factory, where colonies they do a lot of activity. So that is one of the risk factor. What is one more important here, apart from she being there, which is I'm little worried also. What is that?
Yeah, there's a behavioral issue, sir. Sniffing nail polish since the last 6 months.
Yeah. On deep underlying repeat this thing, mother has to be confident in the bag and she's whenever comfortable or she's alone. So this is very important history. This is one of the triggering factor, as well as we should consider a behavior problem also. You're
Yes.
asking fever?
To rule out any infective causes, sir. Pneumonia.
Sometimes viral trigger infections will be there. That also causes exacerbations.
Yes, sir.
Wet cough.
Yeah, any cough with expectoration, sir. Usually asthma cough is dry in nature. So that also points towards likely an infective etiology.
More so into what?
More so towards tuberculosis or even hemoptysis, night sweats.
No. I'm talking about wet cough. Adolescent girl with recurrent respiratory issues, exacerbation, not to solve the issue, not to forget about bronchitis with wet cough.
Okay, sir.
Hemoptysis are there. Okay. Thank you. Somebody has asked, but Smita Satovia has answered bronchitis. Thank you, ma'am. Nice. Good interaction is going on. Next,
No history of any contact with any TB patient, sir. No history of regurgitation or acidity issues to rule out a GERD.
no, we're asking. Of course, in adolescent, it is not so common, but still you should not forget if it is a refractory asthma, not to forget about GERD. Okay, next slide.
Coming to the past history, the child had similar recurrent episodes of cough, breathlessness, chest tightness, and wheezing in the past 3 years. She's had 3 prior hospitalization over the 2 years for similar complaints suggestive of acute exacerbations of asthma. Between episodes, she has had intermittent symptoms managed on OPD basis, and she takes inhaled corticosteroids intermittently. Also, she is a known case of drug hypersensitivity to diclofenac, which she had taken for generalized body ache, and which related in history of worsening of those respiratory symptoms following the intake of diclofenac. This led to a PSU admission, which was on admission noted to be, the child was noted to be in shock and in hypotension. And this was primarily attributed to the diclofenac allergy. And this episode happened over 8 months ago.
Okay, I am just clearing because, no, go back. Go back. There was very important, some technical issue was there. Some technical issue was there. Dr. Sushma, I'll read once again this past history. She had recurrent admissions for the same with exacerbation. That is one thing. She is on OPD basis taking. What is that important? Taking ICS?
Intermittently, sir. She's not a regular. Adherence is bad.
Intermittently. For one admission, we give for long time. One ICU admission itself is go for long time. That's the dictum. She is taking ICS intermittently. And she took for some patient infective arthritis, she took one diclofenac tablet and she was in ICU given hypoventilation. She was in shock as such. That history goes and the record shows she was in shock, revived within it was a daycare admission. She was shifted to ward. That was the sensitivity. She was first time she has developed this drug hypersensitivity. Then let me know here what is the history, what is the important issue here?
NSAID related allergy to the child, sir.
Before that,
Leading to
before that,
poor adherence, sir.
poor
Leading to
adherence.
repeated.
She is
Yeah.
adolescent. She is not taking medicine properly. That made us like multiple admission. Dictum is one ICU admission. She should be a long-term inhaler. She is to drop out the inhaler because of the various reasons. She is not willing. Maybe the problem is with us. We are not able to convince her properly, not counsel properly, or she has got her own issues which we don't know. So two things here. One is the ICS intermittently she is taking, poor adherence. Then another is drug hypersensitivity to eclanin. Let me know what is the relation between drug hypersensitivity to asthma. What is the percentage?
Yeah, around 8 to 10%, sir.
It is one of the predisposing factor to be any drug allergy for that matter. And here we should be more cautious. It tells about she is more sensitive with she is being admitted with hypotension. Okay. Next, here important is ICS not been taken properly. Yeah.
Yes, sir. So, coming to medication history, sir, she has been on inhalation therapy with inhaled corticosteroids with long-acting beta agonists, formoterol, with poor adherence. And also she was using short-acting beta agonist salbutamol as reliever medication, sir, primarily. She has received nebulization with bronchodilators, meanwhile, during those exacerbations with good response. Also, there is history of irregular compliance to controller therapy, sir, with improper and irregular usage of spacer. There was a deficit in the way she used the spacer.
Yeah, what is that here? Medication history is being started as per the guidelines. The says the formoterol is the combination, what are the guidelines says. What is the important thing issue here? What is the important issue?
The issue is that she is not using the spacer appropriately, sir.
Very
Drug delivery is
important.
not
Whatever
taken
the
care.
age, what the guideline says, even in the elderly age, you should use the spacer. Because percentage of deposition with use of in a spacer, it is around to 30 to 40%. Without inhaler, only 8 to 10%. When it is exacerbation, only 2% of the medicine goes. So better to, so here there is issue. She was taking the inhaler whenever needed and not taking, and spacer is not at all in her books at all. So this is one more issue. Next.
Allergy, sir. We have discussed the NSAID induced allergy, sir. Also, there is history suggestion of atopy with symptoms triggered by dexter exposure, seasonal variation in symptoms, and there is no history of any food allergies or any reactions to milk, egg, nuts, or seafood.
So food, she is okay, except for the drug. Exposure to dust, there's no history of other sensitivity except for the urticaria. Okay.
Yes, sir.
Always when you're talking about adolescent history, take the allergy history separately, environmental exposure separately, predisposing factor separately, then only you'll come to some conclusion. Next.
Family history, sir. She is the only child of a couple from non-consanguineous marriage. There is positive history of atopy, sir. Father is a known case of asthma, currently not on any treatments.
Here, maybe you are not gone in detail. The thing is, father is not with them. That is also one of the issue. Yeah, fine.
Birth history, sir. Term
Yeah,
female
anything
2.9 kg.
contributing because sir is waiting. Any contributor in the factors in the birth history?
No, sir. Uneventful, sir.
Good
No
size
issues.
baby.
No
Yeah.
issues.
Okay, next.
Immunization, immunized appropriately as per NIS, sir. But she has not received high-risk vaccines such as influenza and pneumococcal vaccine.
Yeah, it's related to some pertaining to the, especially in adolescent with a known case of asthma. Influenza has got its own benefit if the position papers are there. Good, you asked that issue.
Coming to the diet history, what we observed was there was a excess intake of calories of around 440 calories and excess and deficit of protein of 30 grams. We noted that her food was rich in junk food and oily food.
Actually, the thing is, if you take, it is not the food she was taking. But every she used to consume the roadside food. Next.
Developmental history, sir. Currently, child is studying in 10th standard. She is having
Yeah.
aptitude to poor scholastic performance with frequent school absenteeism, may be attributable
How we know?
to the
How we
recurrent
know she has got
exacerbations.
poor scholastic performance?
Her grades are always borderline, sir. She is in the just pass category, or she is having C plus C, that grade, sir.
Okay. One more thing is, she till 7th she studied in Kannada medium. After 7th she was shifted to English medium. One more contributory factor.
the reason.
Yeah.
Very important.
We
Very
can't
important.
blame her that school performance. She is average taking, but her English is not good. She also find it difficult now. Yeah. And absenteeism maybe because of the exacerbation and the absenteeism that is there. But we can't blanket statement. We can't say that poor scholastic performance. Yeah. Next.
Coming to socioeconomic and environmental history, they belong to a lower middle class socioeconomic status according to modified Kuppaswamy scale. Father is the earning member, and adequate housing, sanitation, and safe water is present. As mentioned earlier, the house is situated near an incense stick factory, which receives a lot of pollutants. So that may be a possible trigger as well. There are no indoor pollutants or no exposure to tobacco
In
smoke.
their locality, many gets like this, especially the elderly people, they got a lot of COPD, they do work, they have to work for that, whatever we say. That whole locality is meant to make the incense sticks. Okay.
Menstrual
We
history,
want
sir.
him to put traditional way of presentation, because what happens in case presentation, they'll just straight away go to the diagnosis. As a PG, he has to undergo through proper presentation. Anything here? Menstrual history?
Nothing significant, sir.
Okay, fine. Next.
Coming to heads assessment, sir. She lives at home with parents and in a stable home environment, good relationship with family members. And education, she is studying accordingly in an age appropriate class. School attendance may have occasional absenteeism due to exacerbations. And activities, there is limited participation, sir. Earlier, she was participating in Coco, but since she is having repeated exacerbations, she is completely reduced that. And that is led to increased screen time usage as well, sir, at home. And nail paint sniffing, like we discussed since the last 3 to 6 months. And no history of any sexual activity, no history of any low mood, depression, no suicidal thoughts of self-harm. Coming to the summary of the case, just based on up to the examination point of view. This is a 15-year-old adolescent girl who is a known case of asthma who presented with cough and chest tightness for 1 week, associated with breathing difficulty and wheezing, which are worse, especially in the night and early morning. She's had a recurrent history of similar episodes requiring hospitalization 3 times in the past 2 years, which suggests poor adherence and poor asthma control. There's also poor inhaler use with the spacer, with recent exposure to new environment, which there's a change of residence. There's a history of atopy as well, and a family history of asthma, indicating a strong allergic predisposition. She also has a history of NSAIDs, suggestive of NSAID exacerbated respiratory disease, with behavioral issues like history of sniffing of nail paint.
What is it overall tells you? Overall summary tells you what?
Yeah, most likely an obstructive disease pattern, sir.
Yeah, then
there is poorly controlled or poor
a
adherence,
poorly
moderate
controlled case.
persistent asthma.
It's a poorly controlled obstructive airway diseases. Okay. Next.
Coming to the vitals, she was afebrile in presentation. She had mild tachycardia with tachypnea with Pram score being 6. Blood pressure was between 50th to 90th centile, and saturation was 93% on room air. Peripheral pulses and peripheries were well felt and warm. Coming to the anthropometry, these are the observed weight, height, and BMI values. The inference of this child was.
Chart you have put?
Yes. So the BMI for age chart was especially high. It was more than 25. So it indicated obese child for both age and gender.
What is it suggestive here? What is that it suggestive of? So far you told multiple risk factor, multiple predisposing factor, poorly controlled asthma. Now we are telling something. What is that?
Yeah. Obesity, sir.
How obesity adds to the poorly controlled asthma?
Obesity is also a state of chronic inflammation. It will result in reduced lung compliance and increased airway hyperresponsiveness as well.
Is one of the important comorbidity. Either obesity itself trigger asthma or asthma triggers, because it's not the obesity or the poor diaphragmatic control. It is not so. It is a lot of other inflammatory mediators are released that causes the exacerbation. Okay.
Coming to the head-to-toe examination, general appearance, the patient is conscious, alert, and oriented. At rest, the child has very mild respiratory distress, well-built but obese. Head and face, no facial puffiness, no sinus tenderness is seen. Conjunctiva is normal, no pallor or no allergic shiners. And no nasal discharge, no nasal polyps are seen, but nasal terminates seem to be enlarged. Oral cavity, mucosa is moist, no tonsillar enlargement is seen or no postnasal drip is seen. Neck, no lymphadenopathy is seen, but there is presence of acanthosis nigricans in this 15-year-old. Extremities, no edema is seen. SMR staging stage 5. Skin is dry and there is no cyanosis or clubbing.
No. Important. Let us next step. Please go to the important here is obese, right?
Yes, sir.
And terminates are enlarged. That tells about the recurrent rhinitis. No lymphadenopathy, ash fever, whatever the extrapulmonary. And important is no clubbing. Says that once again she is not into the chronic lung diseases. Okay. Next.
Coming to the systemic examination, respiratory system on inspection, chest was bilaterally symmetrical. There was increased respiratory rate noted. There was mild use of accessory muscles. No chest wall deformity was seen. In palpation, trachea is central. Chest expansion is bilaterally equal but slightly reduced. There is no tenderness. Resonant note heard over both lung fields. On auscultation, however, there was bilateral air entry present, but it was slightly reduced. There was diffuse bilateral expiratory wheeze heard as well, which was having a prolonged expiratory phase. No crepitations heard. And cardiovascular, abdomen, and central nervous system were all within limits.
Okay. On that day of exacerbation, child had diffuse bilateral expiratory wheeze. Says that there is obstructive airway diseases. Okay.
Coming to the investigations, the complete blood count showed eosinophilia. Both the CRP and ESR markers were normal, within normal limits. We noted that absolute eosinophil count was elevated and even the serum IgE levels were also elevated. Here, chest X-ray was also done, which showed hyperinflation. Spirometry we did when the child was stable post the discharge.
1 minute. Is that required, Dr. Amit? 1 minute. Don't run. Please. Why this absolute serum IgE is required?
Yeah. Marker of eosinophilic this thing, sir.
That tells about, but it's not mandatory to prove that your asthma diagnosis is being done. But it's not mandatory. Please. Because if you are in Bangalore, definitely 90% of us will have positive, even in other cities also. Why you took X-ray?
Chest X-ray, I agree, sir. It's not routinely indicated in asthma, but to make sure to rule out other causes, sir, to rule out any other infection or why there was a repeated admission.
Why you wanted to do spirometry on the day?
We did it after discharge, sir, when the child was stable.
Okay, fine. There's no point in doing on the office hours, except for if you want to triage, you can take the PFR. Okay, what is that suggestive of?
Spirometry, we observed an obstructive pattern, sir. There was expiratory scalloping of the wave, where we noted there is a reduction in FEV1 and especially FEV1 by FVC ratio, sir. And also we noticed a good improvement or reversibility post bronchodilators.
Here, actually, already patient has responded properly. Reversibility definitely is there. Anyway, if you are done, it's okay. Any other test you have done?
Yes, sir. We did pheno as well, sir. We noted a very high value.
What is that suggestive of?
It's suggestive of eosinophilic inflammation, sir. Fractional exhaled nitrous.
So here, take care of your observatory count and serum IgE. Chest X-ray need not be. Spirometry only if necessary, or objective evidence. It's not that. If spirometry is not there, what you do?
We can go ahead with peak expiratory flow rate, sir.
Fine. Do you use it in office practice? You do recommend? Especially for adolescent, that is ideal.
Yes, sir. This was the spirometry graph of the child when it was done on follow-up. So here we can see the expiratory is scalloping a little bit and reduction of both FEV1 and FEV1 by FEVC. Coming to the provisional diagnosis after the examination and workup of the patient, I would like to consider this to be acute exacerbation of moderate persistent asthma in a 15-year-old obese adolescent girl with poor control, likely compliance or adherence issues, with other comorbidities like allergic rhinitis and atopic dermatitis, with history of NSAID sensitivity, likely to be obstructive pattern of disease. Coming to the treatment given, first we managed the acute exacerbation. Oxygen supplementation was done to maintain the saturation above 94%. And salbutamol with ipratropium bromide was given, 3 back-to-back, and then spaced accordingly. And oral prednisolone was started at 2 mg per kg per day, and close monitoring of respiratory status was carried out. And post-stabilization, the child was started on MART therapy and stepped up to track 1 as per GINA guidelines.
What is that MART therapy? What is MART therapy?
Sir, I cannot hear you. Sorry, sir.
MART therapy. What is
MART
MART
therapy.
therapy?
Okay, maintenance and reliever therapy, sir.
What is the
Low
duty of
dose ICS with
Sir?
formoterol or
This acts as a reliever as well as a preventer,
yes, sir.
especially for that age. But here issue is maybe we are not counseled properly. Our technique was not observed. We are not given much time. She has not used the spacer properly. Okay.
Also
Next.
coming to the management of other comorbidities, for allergic rhinitis, we had started on intranasal corticosteroids with antihistaminics, and for atopic dermatitis, emollients and topical steroids.
Why you should give allergic rhinitis? Why you should treat allergic rhinitis?
If we treat the allergic rhinitis, further exacerbations of asthma is reduced, sir.
Don't neglect the sneeze, you will get the wheeze. There is a proverb. There is a big study. If they do allergic rhinitis, they have done the pulmonary function test. In terms of obstructive airway disease, their pulmonary function was so on treatment of nasal spray, there was improvement of lung function also. Always you should treat the allergic, one of the comorbid condition.
Yes. The next line of management was avoidance of triggers and avoidance of drugs, sir. Especially environmental control, the dust, the pollution and cold exposure, and strict avoidance of NSAIDs. Advised to use paracetamol as a safe alternative. Also, she was advised against using nail paint for sniffing purposes, sir. Both the mother and the child were counseled.
Do you advise drug hypersensitivity test anything? Do you advise drug hypersensitivity test anything? Once you know the history better, because it is a challenging, doing a double is not easy. They'll go to the shock and other anaphylaxis. So when you know the history, be careful. Rather than go with your history and manage with a safe alternative. Okay.
Okay.
What is the important is your treatment guidelines you follow. But non-pharmacological management is very, very important. What is that you are added?
Yeah, especially inhaler technique with proper training with spacer was introduced to the patient, sir. Usage of spacer and how she must use it, that was properly taught to her and both the parents. And adherence counseling was carried out both to patient and parents. Lifestyle modification was advised, weight reduction, increased physical activity, and adequate sunlight exposure.
The important is weight reduction, increased physical activities is very important. Okay, then any other, what about the yoga, fish therapy, everything they advise?
Yoga can be done, sir. And if the child is willing,
supportive.
Yes, sir.
We have presented twice in American Academy of Pediatrics, which is supportive. It doesn't cure anything. It adds to it. Fine. Important is inhaler technique is whenever patient comes, especially adolescent, each visit you should take care of the inhaler technique and the spacer. Next. Thank you. Thank you. The stars, just tell them.
Sir.
Even our former Prime Minister was there. It's with sir can give comment and 2-3 lines he has got on adolescent asthma. Specific time permits I will add. Otherwise, let me know. Sir is there. Sir should give comment.
Sir, Nair sir.
First of all, I must congratulate Amit for an excellent presentation. Very detailed, minutest. And Dr. Somasekhar for pulling everything threadbare. Every single aspect, he has attended every small things, which is so important for examination purpose. My only comments would be, I think there was not enough emphasis given on indoor pollution. I didn't hear him talking about pets in the family, whether pets are in the bedroom. How do you clean the bedroom? Do you wipe it first, mop it first, and then, do it, jadu martaya, or just do first, do it, and then wet mopping later? It should be the wet mopping should be first, because whatever dust, not only dust, mites in the corner of the room should not go into the air, because that's why the asthma becomes bad. Then about using blanket, particularly, I think it is winter time for in Bangalore, then that is important. Even sheet cleaning, if you leave the sheet like that, nothing will happen. But if you do like this, the whole, dust will come into the air. So most of the things that we do to keep it better actually harm that person. So that is the one point. The second point in the examination, not so important, but I think since it's been a little chronic, is there any signs of emphysema? Because when you percuss, you can see whether the signs, because you also said child had some breathing problem at first also. Not enough, 15 years is not enough to produce emphysema, but it could, early markers could be there. Then one more small important thing, not so important, any relation to menstrual cycle, because some girls actually asthma become bad during the menstrual cycle. So these are three only points you can respond to that. Amit, you can respond to these 3 points.
Yes, sir. Sir, coming to indoor pollution, sir, they do not have any pets at home. And they are not well aware of how to use dry and wet mop, sir. We had to educate them. We advise them to first use the wet mop first instead of using the dry mop to sort of spread the dust everywhere around. And there was no relation to menstrual history, sir. The asthma attacks did not coincide during the menses. And no signs of emphysema were noted, sir. No signs of any chronic lung disease noted as of now.
Not only menstrual, it's also full moon. Is in a relation to full moon. Because it is said that, actually it's observed also that asthma can worsen during the full moon period. Just
Sure,
check
sir.
on that.
Okay, sir.
There are some evidence on that. Yeah.
Okay, sir.
As a traditional, knowledge, Sushma bhai.
Yeah,
Sushma,
so
what
I
do you
was
say?
just going to ask you, sir, is it related to some kind of a mental stress, or because it is in some of the literature, it is mentioned that full moon is associated with exacerbation of some mental health issues. So maybe that may be the reason. Otherwise, what can be the reason behind exacerbation during full moon? I think there is. So this can be the reason, right, sir? Okay, I think that was an excellent presentation. Dr. Amit, actually, Dr. Somsekhar has given so much of, insights, and so, well, it was so enriching, the discussion between the duo, that there is hardly any question which is left. And I keep the house open for any question, one or two we may entertain, otherwise we can take it up at a later stage. So is there anything you wanted to say?
Say something, Sushma, Dr. Sushma.
Sir,
Amit,
please,
just one
sir,
thing.
please.
Yes, Amit, you have done very well. There are few little more things. Pets, sir has already mentioned. Cleaning and changing bed sheets in the evening, we advise. And you need to ask about vaping also. Now it's a very vast trend. And we have to mention something about exercise-induced asthma in the management. One important point I wanted to mention is to make it more impressive and in the games more scoring, we could have given a table on Prem score and
Okay,
we
sir.
full form so that you are not only presenting, you are teaching others also. So I think we have to give in the assessment of the patient 5 components of Prem score in the table form and the values. And you have mentioned score is 6. What do you mean by 6 score? So we have to give mild, moderate, severe scoring system so that this is a learning experience for others. And you score very good if you present this way. Thank you.
Noted, sir.
Sure, sir. Sure, sir. Thank you.
Thank
Amit,
you. Yes, sir.
Amit, just run the slide, that last few slide immediately because the others.
Yes, sir. Is my screen visible, sir?
Yeah.
Yeah. Since this is an adolescent specific gathering, would like to talk
Quickly you go through that.
few slides on adolescents. So adolescent specific issues contributing to poor control. So what we have observed in behavioral and psychosocial factors is there is poor acceptance of chronic illness, and there is denial or minimization of symptoms which take place. And there is irregular medication use due to feeling normal between episodes. The child here in question used to feel normal in between, so she thought she did not need any medication further at all. And also coming to body image and social concerns. Since the child is obese already, she has some body image issues, and that led to further avoidance of inhaler use due to peer perceptions. Using inhaler felt a bit different to the child, or she thought that the others thought her was to be sick, and she also thought using inhalers they contain steroids and they led to weight gain. Coming to school and peer pressure, there was reluctant to use inhalers in schools and especially public settings, thinking that something is abnormal with her and so she doesn't need to use it. And there is a certain stigma associated with the asthma status as well. And also in adolescents, what we observed here was that there is a conflict between the autonomy and the supervision. As we all know, this is a transitional phase in age where there is reduced parental supervision and there is increased self-management. But there is very poor responsibility at the same time as well. And coming to family support, sometimes the family was noted to be overprotective and sometimes even inconsistent, saying the kid did not need, she was all right, she did not need any inhaler therapy. And there was also what we observed was there was lack of awareness and structured education around the asthma. So coming to why adolescent asthma is physiologically different, there are a lot of hormonal influences which take place here as well, which affect airway inflammation, and there is increased airway hyperresponsiveness, and obesity related inflammation also worsens asthma, and there is higher incidence of non-eosinophilic asthma phenotypes, especially in adolescents. And there is poor perception of symptoms, which leads to sometimes delayed care seeking, further aggravating the condition. So we sat with the child, we sat with the parents, and we had a proper counseling done. So our approach to the counseling was we try to build rapport with the child. We try to acknowledge that the challenges and the issues that the child is going through currently, and we also try to address and remove the stigma attached with asthma. So we wanted to normalize the use of inhalers, especially with spacers. She was wearing spectacles, so we told it's basically like wearing glasses. It's part and parcel, and it doesn't make you look sick or uncool. And also we talked to her more, and we understood what were her reasons of poor adherence. She considered that she was completely normal in between the periods of normalcy, and she did not need any inhaler use. And we also emphasized self-control over the disease and not the disease to take over the kid. And we made sure that there was a stress on regular medication use, and we promoted adherence, especially to the inhalers. We encouraged her to do any activity she likes, and we made her a routine-based action plan. Also, we counseled both the family and the child. We agreed that there should be a daily routine for medications, especially at what time, what needs to be taken, and we educated both the parents and the child regarding that. And we demonstrated the inhaler technique in detail. We made sure that the inhaler is to be taken with the spacer and not otherwise. And we gave a asthma action plan, and we set realistic goals. The idea was to improve our school attendance gradually and improve our physical activity gradually over a period of time on regular follow-up.
As well as for our action, sports, we told her to do pre-warm exercise and take the inhaler one extra so that our performance increase over a decremental way.
Yes,
Yep.
yes.
Yeah, this is just a sample of the asthma action plan we gave to the child. So basically a document which helps to monitor symptoms and what to do in case of certain emergencies. It will also tell the patient whether they need extra puff of inhaler or not. And also this will help the family members know to how to react during a different situation, and also keeps a record of all the events. So the key learning points, what I learned from this case were, asthma in adolescents is especially unique. It's not just a respiratory disease, but a biophysical condition as well. It requires not just treating the medical aspect, it requires addressing the behavioral, emotional, and social factors as well. And recurrent exacerbations usually means poor control in adolescents. Frequent hospitalizations in this kid also indicated suboptimal asthma control. So it is imperative that we always evaluate adherence, inhaler technique, proper usage of spacer, and reduction of trigger exposures. And also we noted that adherence was one of the biggest challenges in adolescents, because they have poor compliance and over reliance on using relieving inhalers. And they, as we had discussed, they deny the illness and they are forgetful, and they do not want to look sick or uncool amongst their peers. So psychosocial factors also matter a lot in adolescents. Peer pressure, stigma attached with asthma, and body image concerns also impact the treatment and adherence. And avoidance of using these inhalers, especially in school or public, leads to poor disease control. And atopy and family history are also key clues. They give a strong genetic and allergic predisposition of the issue as well. And here education is crucial. Both family, patient, and even the schools need to be involved, especially the teachers, the PT teacher, nurses, ayas, and even the principal as well if need be necessary. So it's important to use inhaled corticosteroids regularly and correct inhaler technique. And overall, holistic management is extremely essential. Pharmacotherapy, lifestyle modification, and psychosocial support. Thank you.
I think that was all, and the time is also over. So we will have to move on to another case. I think the study, and I welcome and I invite Dr. Yash, whose mentor is Dr. Mamta Mohanty, to start your presentation, please.
Thank you.
Thank you, Amat, and all the best, Yash and Mamta. Thank you.
Thank you.
And
Thank
thank you,
you all
Dr.
for the-
Somsekhar, for a very excellent case, mentoring that case.
Thank you, sir.
I think Somsekhar should be thanked extremely for doing this good discussion.
Bilkul.
MD.
Very nice discussion. Yeah.
Thank you.
Hello. Can I know my screen is visible?
There are a few questions from
Yeah,
the
it is
audience,
visible.
but we will take it later on.
Can I start the presentation?
Yeah.
Good afternoon. Hello.
Yeah, you're audible. Start your presentation.
Good afternoon, everyone. A respected chairperson, faculty member, and my dear colleagues. I'm Dr. Yashwant, here to give a presentation on the topic prevalence of orthorexia nervosa in adolescent social media users, insights from an Eastern India adolescent population. This study was done under the guidance of my mentor, Dr. Mamata Devi Mohanty, Professor and HOD, Department of Pediatrics, IMS in Bhubaneswar. The presentation will be structured as follows. I will be giving a brief introduction about orthorexia nervosa, followed by I'll be telling my objectives, later the methodology and results, and finally we'll conclude with the key findings of my study and references. So let us begin with the introduction. Orthorexia nervosa is an emerging eating-related disorder characterized by an obsession with eating healthy or pure food. The first mention of the term orthorexia nervosa was given by Dr. Stephen Bradman, was in around late 1990s. Orthorexia generally comes from a Greek terminology. Ortho means right, and orexis is appetite. It was introduced to describe the patterns of unhealthy obsession for healthy eating that emphasizes following extreme rules on clean and pure nutrition and unreasonable specifications for food selection or preparation. Current understanding defines orthorexia as an overvaluation and preoccupation with food quality and its impact on health. Even the term orthorexia nervosa was first mentioned around 1990s. There were very limited publications about orthorexia nervosa in early 2000s. The main turning point of orthorexia story arc occurred in 2014. This is one of the earliest real-world example of orthorexia gaining a global attention, where an Instagrammer named Jordan Younger,
और डिपार्टमेंट चेंज हो गया यार
with an with the
क्या
Instagram
काम है
name
तुम्हारा
Vegan,
वही मैं सोचू दिख नहीं रही हो
confessed
आजकल
to being orthorexic.
अच्छा कैसा
She
यार
was She was known for promoting extremely clean, unrestricted eating habits, but eventually she understood that her this pursuit of healthy eating had become harmful. She later described her struggles with orthorexia in this book called Breaking Vegan, where she explained how the obsession with food quality led to very nutritional deficiencies and psychological distress. This slide I want to tell like in a importantly this the entire behavior of her was reinforced and amplified through social media. Like she tends to follow clean eating. She posts about the clean eating in Instagram. People start liking it. People start following her. People start praising her. It creates a sense of validation, whereas it creates a sense of pressure to maintain her image. Moreover, it tends to go into an extreme behavior over time, which forms a reinforcement loop here. And not only this, there are many other sport activists, fitness influencers or athletes who went through this orthorexia. These are two articles about a professional athlete called Dee Luwad who had similar problems, and a wellness influencer called as Lee Tillman also had similar tendencies. And these are importantly, these patterns were influenced and reinforced by social media exposure, raising a concern about similar risks in adolescents also. And yes, we are beginning to see similar patterns in adolescents. There have been many real world consequences associated with extreme diet behaviors recently in newspapers, etc. One of the content is, for an instance, a 17-year-old adolescent reportedly followed a restrictive juice diet, only diet for a couple of months without any professional guidance by seeing through online platform. This further emphasizes the need to understand how the social media can influence on the eating behavior of adolescents, and which forms the basis of our study. So, for instance, we can see some hypothetical situations where generally we see in OPD, where if mother comes to us and she tells doctor, my 12-year-old daughter has stopped eating junk food completely. And then she adds up saying she cries if the food has even a drop of oil. Would you congratulate her or would you worry? Or if a mother comes and says ki her 13-year-old girl who came to OPD is not for weight loss, but she hadn't eaten any proper meal for 3 days. Then you ask her, why didn't she eat any proper meal for the last 3 days? She says ki there is nothing available at home was healthy enough. This is not about the diet management. It's about the unhealthy relationship with the food. So orthorexia nervosa is not formally recognized in DSM-5 or ICD-11, but is increasingly reported in adolescents. Orthorexia nervosa might start as an innocent attempt to eat more healthy, in which attention to food selection is not pathological itself. This attempt might turn into a highly absorbing obsession that penetrates almost every aspect of orthorexic individual's life. Orthorexia nervosa, unlike anorexia, is not associated with any weight loss strategy.
I think her connection is a bit unstable, right?
Yes, madam.
Dr.
We
Mamta
lost his-
Devi.
Doctor, yes. I think it's not, his connection is somewhat disturbed.
Yash, are you there?
वीडियो बंद कर दें या तो
हाँ बिल्कुल
Mm.
अरे कनेक्शन गया लगता
join
है
हो जाए।
इसका हाँ
First he has to join again, then and then everything.
हाँ डॉक्टर ममता जी आप प्रेजेंट कर सकते हैं उनके बदले में, और ये सिर्फ बंद करके बोलेगा, मीन्स यू कैन शो द आर्टिकल। और शामिक जी आप कर लें, अपने ग्रुप में है।
Ma'am, just a minute. Dr. Mamta, can you call Yash and find out what is the issue?
I'm calling, sir.
शामिक जी आप
Hello.
डिस्प्ले करके देखेंगे।
I'm trying.
आ गया, आ
Hello,
गया।
I'm sorry, ma'am.
यस,
There is a
हाँ,
signal.
आप अपना वीडियो बंद रखें और सिर्फ प्रेजेंट करें शेयर करके, आपका स्क्रीन शेयर करके, तो शायद थोड़ा कम डिस्टरबेंस रहेगा। ठीक है डॉक्टर यश? आई थिंक ऑलरेडी गॉन, वापस हो गए। क्या करें डॉक्टर यश? अमित जी आप डॉक्टर ममता जी को कॉल करें
Yeah, I'll just call.
एंड
Yeah,
आप
he's
प्रेजेंट करें।
He's
हाँ,
he's joining, madam.
he is joining।
Just a second,
आप क्या
she's
करते
joining.
हैं, हम क्या करते हैं, स्क्रीन शेयर
Yeah.
या तो आप करें या डॉक्टर शामिक कर लेंगे, और लेट हिम स्पीक।
Dr. Mamta, if you have his updated presentation, can you do
डॉक्टर
the screen
मनमीत के
sharing?
पास भी रहेगा, डॉक्टर मनमीत के पास भी रहेगा, आइदर ऑफ यू।
आप 2 मिनट बैठ जाओ बाहर, 2 मिनट बाहर बैठ लो। Ma'am, actually, I am taking MBBS exam. Actually,
Oh, sorry.
exam is going on, so that is the
No
reason
problem.
I'm logged in.
No problem। ममता जी
I
आप
could not.
प्रेजेंट कर रहे हैं।
Ma'am,
शामिक,
there's
I
some
think
issue
Dr.
with sharing.
I don't
Yeah.
know. He has some internet issues. तो शामिक जी, I think डॉक्टर ममता सॉरी मनमीत ने अपने ग्रुप पे ये करा है।
हाँ मैम, I have shared in the group already.
आप प्लीज प्रेजेंट करें, या डॉक्टर समीर भाई आर यू देयर? प्लीज हेल्प अस,
हम लोग
थोड़ा टाइम सेव करें प्लीज।
Okay, ma'am. Let me see. Ma'am, Mamta ma'am, it is not possible to share from your end.
शामिक आप या समीर भाई चालू कर दे प्लीज।
ये करते
Ma'am,
ma'am.
I'm trying
He'll
to
be here.
find out,
He'll be
ma'am.
here. Just a minute, ma'am.
शेयर नहीं हो रहा।
Can you send it to me, Dr. Manmeet? Can you
Yeah.
send it to me straight
It
away?
is in the group actually. I'll just share.
Trying to find out.
I've shared.
Have you given it to me personally?
Yeah. To you personally.
Yes. Okay. Okay, I'll share it. Just give me 1 second.
Whether Yash is available to read or not. That is first important.
Okay, Yash is not visible actually. That is what I was searching. Yash नहीं दिख रहा है।
If it,
डॉक्टर ममता आप प्रेजेंट करते हैं उनके बदले में?
Ma'am, I'm doing it, ma'am.
नहीं
नहीं, sir,
प्रेजेंट करने
लेकिन
की
वो
बात
बोलने
कर
के-
रही हूँ मैं।
Just a
पढ़ने
minute.
के लिए हो।
अरे वहां जाके प्रेजेंट करो ना। पीपीटी शेयर करें ना सर।
We are sharing the PPT. Just he has to read that thing and continue the presentation.
Dr. Mamta, are you there?
Ma'am, I'm
Yes,
sharing it,
madam.
ma'am.
Yes, madam. He's joining. He's joining.
I've shared it if you can read.
Yeah, it is visible.
Okay.
Slide show कर दीजिए डॉक्टर शामिक। Yeah, okay, done.
Done. बराबर।
डॉक्टर यश आप
मैं
अपना
कर
वीडियो बंद रखें और फटाफट प्रेजेंट करें। आप अपना वीडियो बंद
Start
रखें।
speaking. No, now he's here. I think I'll share the slide. Come on, quick.
No.
We have already
Can I
shared
share
this
my slide
slide.
from my side?
I have already
Yes,
shared. Yes, just
yes, there
be
is no.
calm. There's nothing to hurry. I've shared the
Yes,
slides.
शांति से काम करो. चलो.
I've shared
Samik,
the
he will be sharing his
slides.
slide now from his own. Please
Okay.
stop sharing.
Yes, sir. Can I share my slide, sir? If possible,
Yes.
share it.
I'll stop sharing.
Yes.
Okay.
उनका
Yes,
वॉइस नहीं सुनाई दे रहा है. तुम्हारे कहीं म्यूट रखा है क्या?
Sir, my slide is visible.
Yes, it is visible.
Not
Hello,
as
sir.
yet.
Is my slide? Can I please know from what slide I need to start now?
It is.
Yeah.
From
You had given your objectives.
I'll start from introduction.
You had
if
given
possible.
your
Can I-
objectives, so you just
Objective,
move
yeah.
ahead.
Try to make it full
Full
Yes, sir.
screen करके.
if possible.
Yes,
If
sir.
possible, just make it full screen.
Yes.
Visibility will be better.
Yes, sir. It's full screen only, sir.
Yes.
So should I start from introduction again?
Yes, please first.
Orthorexia nervosa is an emerging eating-related disorder characterized by an obsession of eating healthy or pure food. The first mention of the name orthorexia nervosa was given by Stephen Bradman in late 1990s. Orthorexia generally came from the Greek term, Greek terminology, where ortho means correct and rexis is appetite. It was introduced to describe the patterns of unhealthy obsession with healthy eating that emphasizes following extreme rules on clean and pure nutrition and on unreasonable specifications for food selection or preparation. As per the recent current studies and all, orthorexia is defined as overvaluation and preoccupation with food quality and its impact on health. The basic turning point of orthorexia came around 2014 when even though the term was actually coined around in 1990s and all, around 2014 because of an Instagram blogger, because she shared that she's having announced herself ki she's from like having orthorexia, and people because excuse me, signal issue. All right. The turning point in orthorexia story arc occurs in 2014 when a popular Instagrammer and blogger, Jordan Younger, with the name of Blonde Vegan, she confessed being orthorexic. Younger, detail in her the book called as Breaking Vegan, described her story about her journey with orthorexia. And this slide I want to tell in a way because her behavior of orthorexia was reinforced and amplified by social media exposure. Because once she started posting about the clean eating and healthy eating and all, people started liking her post. People started following her, which made her to do it repeatedly, which made her to pressure to make the image right, which created a reinforcement cycle. Which amplified the orthorexia habit. This was also seen in other individuals, other athletes and health influencers in condition like Lil Watt and many more. And now we are beginning to see the similar patterns in adolescents also. There is a case where like 17-year-old 3-month child who had alleged 3-month juice only diet, which says that this social media is influencing over the adolescent age group. For instance, if they like hypothetical situations where a mother proudly tells you that doctor, my 12-year-old has stopped eating junk completely, but then she adds up, she cries if the food has even a drop of oil. Would you congratulate her or worry? Or a 13-year-old girl came to OPD not for weight loss, but because she hadn't eaten a proper meal in the last 3 days. And for this, not formally recognized by DSM-5 or ICD-11, but increasingly reported right now in adolescents, orthorexia might start as an innocent attempt to eat more healthy, in which attention to food selection is not pathological itself. This might turn into a highly absorbing obsession that penetrates almost every aspect of orthorexic individual's life. ON is not associated with weight loss strategy. The main difference between anorexia nervosa and orthorexia nervosa lies in the motivation and final goal. Weight loss being the final goal in anorexia nervosa, whereas healthy eating is the final goal in orthorexia nervosa. It's not about how much they eat, it's about what they think about what to eat. So when does this healthy eating habit become unhealthy? No, it's not. No, absolutely not. We should never discourage healthy eating habits. The goal is not to stop healthy habits, but to prevent them from becoming rigid, anxiety-driven, or extreme. Healthy eating habit is flexible habit, whereas orthorexia comes with rigid rules that I can only eat this, or any anxiety or guilt. The child sees if the rules are broken, or eventually they will do social avoidance and nutrition compromise, etc. So coming to the objectives of my study, primarily the primary objective is to estimate the prevalence of orthorexia nervosa among adolescents. Secondary, to assess the association between the social media use and the orthorexic tendencies. This is an analytical cross-sectional study we did in a setting of Bhubaneswar, adolescent age groups in schools, junior colleges, senior colleges for a duration of 2 months. Inclusion criteria include the adolescent age 13 to 19 years with an informed consent from guardians less than 18-year-old. And exclusion criteria includes the people who not approved for the consent, chronic illness or eating disorder previously diagnosed. We took a questionnaire, ortho or questionnaire validated for adolescents using a self-administered Google Forms and paper survey containing socio-demographic data, average screen time, social media details, and ortho or adapted questionnaire. We did the data collection. Coming to the ortho R, which is taken from the ortho 15 scale, contains the following 6 points, which help us to check the rigid or if there is any rigid or restrictive behavior, or the child is feeling any anxious or not, or if the child is changing his lifestyle or etc. with a 5-point Likert scale. So the results we got after the study is a total of 410 adolescents were participating in the study, and the overall prevalence of orthorexia nervosa was 40.9%. Risk was significantly higher among the social media users compared to non-users. And coming to the gender distribution, there was BMI-wise distribution, orthorexic tendencies were more in underweight and overweight, slightly more in underweight and overweight individuals compared to normal BMI. Platform-wise orthorexia risk, we found out that there is a higher tendency with Instagram, followed by other fitness apps and YouTube channels and other apps. While doing the study, we during using the ortho-R, we go through the high-risk behaviors. What most of the adolescent individuals put as always, eating only healthy food improves self-worth was reported by around 33.2% individuals. Worry about purity of food was reported by 27.5% individuals. Eating healthy was better compared to enjoying food was reported by 19.6% individuals. Guilt over unhealthy foods was reported by 13.6% of individuals, and avoiding unhealthy foods at social events was reported by 7.5% of the individuals. So in this present study, the overall prevalence of orthorexia nervosa risk was 40.9% among adolescents. This relatively high prevalence is consistent with the previous studies using ortho-based tools, which have reported wide variability ranging from 6 to 45% in adolescent and young population. The significantly higher prevalence of orthorexia among social media users in our study is consistent with the previous research, demonstrating a strong association between Instagram use and orthorexic tendencies. Similarly, another study reported the increased social media exposure is linked to disordered eating behaviors. These findings suggest that social media may act as a key environmental factor influencing orthorexic behaviors in adolescents. Female adolescents showed a slightly higher predominance compared to male, aligning with the earlier studies, highlighting greater body image and diet-related pressures among girls. The majority of the participants belong to 18 to 19 years age group, followed by 15 to 17 and 13 to 15. Coming to the association with BMI appears variable, and our findings suggest a possible nonlinear trend with both underweight and overweight adolescents showing a little higher risk. The study identified several orthorexic behaviors. The self-worth linked to healthy eating was the highest with 33.2%. Worrying about the food purity was around 27.5%. The preference for healthy eating over enjoyment was around 19.6%. And guilt after consuming unhealthy food and evidence of social eating was also present. These findings suggest that orthorexia in adolescents is driven not merely by diet choices, but a psychological over-evaluation of healthy eating, where food quality becomes closely tied to self-identity and moral judgment. This aligns with the existing literature that describes orthorexia as an obsession with food purity, accompanied by rigid beliefs, emotional distress when dietary rules are not met. The findings suggest that the orthorexia in adolescents exists on a spectrum ranging from normal, unhealthy eating behaviors to pathological obsession. The high prevalence observed in the study highlights the possibility that orthorexia is under-recognized in clinical practice, particularly because it's often initially perceived as a positive healthy behavior. I want to discuss about why the adolescents are mostly vulnerable to these orthorexia tendencies. Adolescence is a age where the child enters in a phase of identity formation phase, where there will be a desire to control, to become perfection, to form an identity, and the adolescent becomes more self-conscious. And there are psychological factors like low self-esteem, perfectionist traits, and social media influence, which shows Instagram trends about or any posts about clean eating trends, which are basically algorithm driven, which shows similar posts back to back as a cycle, which makes the adolescent or an individual to think clean eating is clean eating is the best way possible to become healthy. And also comparison with peers about body image, social validation like likes and comments, and even the parents focus on healthy eating unintentionally may also cause, and lack of awareness. Healthy eating actually is seen as a universally positive thing, so lack of awareness also is a factor why adolescents are more vulnerable to orthorexia. Concluding this topic, orthorexia nervosa appears to be a relatively common and emerging concern among adolescents, with nearly half of the study population demonstrating risk. The significantly higher prevalence observed on social media users highlights the potential influence of digital shaping dietary beliefs and behaviors. Key Manato behaviors in our study include excessive preoccupation with food purity, self-worth linking to healthy eating, and guilt after unhealthy food consumption. These findings of our study highlight the growing influence of social media and fitness trends on adolescent eating patterns. Overall, the results underscore the need of increased awareness, early identification of these symptoms and signs, and appropriate screening strategies in adolescents, especially in context of rising social media exposure. Large longitudinal studies are needed to illustrate the causal relationships with and to develop standardized diagnostic approaches. And my limitations of the study is a relative small sample size, 410, and it is done in a short duration of time, and I didn't go through any age-wise prevalence, was separately not analyzed. And use of screening tool orthoscale, there is a possibility of overestimation according to some articles. And as a future direction, this study is being extended to a larger population for validation and generation of findings. These are my references. Thank you. And I want to end this presentation. Thank you for giving me this support. And with this photo, the catch them early, keep them safe, which is a AHA 2026 team. Thank you so much.
Congratulations. Yes, it was good presentation. I would, yeah, Dr. Mamta, you wanted to say something. Yeah.
Thank you, Dr. Sushma Madam, Dr. Samir sir, Dr. Samit Ghosh, and Dr. Manmeet, giving us this opportunity to present the study of Dr. Yes, who is a very sincere postgraduate in our department. And actually, many parents, they are coming to the OPD to counsel and ask about the food pattern, what they will give to their children, and we counsel them. Still, they have so many questions in their mind. For this reason only, we have this study. So now I request Dr. MKC Nair sir to give his opinion about the study. Sir.
So good evening to all. I think I must congratulate Yash for taking up a very novel idea. It's not so well known, although there are some publications. My problem is little more about methodology. If you plan to publish this study, it cannot be published in this form. The moment you say in the first study, 50% person population has a problem. So there is a problem with the measurement scale. So I'm not sure about the scale that you use, how valid it is, how it has been validated. Does it have discriminant capacity? That means normal, abnormal. How do you do it? Especially when you are using a especially when you are using a Likert scale and making everything on that basis. Because there's no international definition to best of my knowledge. So I think you should have a expert committee making the definition first of all. The IAP can do that. IAP can do a definition first, then the criteria, scale, and all that. There's no pilot study also in this one. So it's a good attempt, but I think you may not be able to publish in any good journal unless you go through, because we do not know the sample size calculation at all. What is the confidence level that you are getting? So the three main issues methodologically. One, the tool itself is suspect, which you also agreed it may be overestimating. Number two, the methodology of sample size has not been calculated. What is the confidence level or the prevalence? If you are doing it's actually a prevalence study. So it needs to be little more thought of before you try to publish it. That's all. Very good attempt. I think
yes, sir. Now we are
should be
doing in
congratulated
OPD and IPD basis so that we can know the exact number of affection of this obstetricia and orgo, sir. He has
No,
done
madam.
only.
The problem is,
yes,
when you are taking up a subject like this, you cannot do it with in the OPD just like that. It has to be done as a proper, well-conducted study with a methodologist, really telling the statistician involved. Then only you can publish. That's the point I'm saying. Okay.
Sure, sir.
Thank you, madam. Also, one more thing, you're linking everything to mental health. No mental health assessment has been done for any of these children. They may be having anxiety, they may be having depression, they may be having obsessive symptoms.
Compulsive. Yeah.
Yes.
Yeah. So
it's very
without that,
difficult to
you cannot
differentiate between these two.
So this is only, very good attempt.
Initial
I'm
thoughts,
congratulating you for that. But at the same time, if you want to publish it, make it more rigid. Okay, that's all the point.
Right. Thank you, sir. Thank you for those excellent insights. And yeah, this was what we had discussed, all those same, I think, similar point, right, Dr. Yash, when you were having a rehearsal. Yeah. So we have to differentiate with some other disorder like OCD. Another important thing is, Dr. Yash, we have, ortho 15, which was, I think, a validated tool that was, I heard from you. And how come ortho 6 come into picture? Because I have not read ortho 6 anywhere.
Ortho R is the tool name, which is having the 6 points of ortho 15. There are articles which validated this ortho R scale from 15 because 15 was giving more prevalence compared. So they took the most important 6 points and they made into an ortho R separate tool.
Is that a public, a community screening tool, or it is what kind of a tool it is? Because what you have done is a community screening.
Yes, like it is not used for diagnosis of the patient, ma'am. It is basically to check the risk factors and orthorexic tendencies in the individuals. And there is no particular diagnostic tool because it's not put in the DSM and ICD classification criteria. And we need to better diagnostics tools in future to diagnose this orthorexia. It's just to make the check the tendency of or risk factors are present or not.
So your idea was the children presenting with orthorexia symptoms. We need to identify. Your objective was to identify the risk factor in them.
Yes, ma'am.
You had shown that prevalence 40+% something.
40%, 40+%.
So
Yes.
you were diagnosing the case and then only you can do that. It was not
there is
the main aim, right? Your aim was to identify the risk factors.
the tendencies, orthorexic tendencies in the individuals, because there is no particular diagnosed protocol to do it, but
Diagnostic definition you do not have, right?
there are 3-4 tools in which ortho-R is the most popularly used tool in public domains, in school, in medical
That is what I
colleges,
said.
everywhere.
It is for community screening, right?
Yes, community
It was
screening.
a
Yes.
screening purpose, not the diagnostic.
The screen the risk tendencies as well, not a diagnostic.
So yeah, so you can say it is a tendency, not
Tendency,
a
yes, ma'am, orthorexic
diagnosis.
tendencies.
Yeah,
Yes.
so tendency, kind of a
Tendencies.
tendency was that high in
Yes.
adolescence, right?
Yes.
Because
Yes.
prevalence, if it is more than 40%, is a very serious thing.
Orthorexic tendencies were the tendency risk, orthorexic risk and tendency is the
Make
thing I
it
mentioned.
very clear in the beginning,
Yes.
and as sir very rightly pointed out, another important factor was kind of, it's a very short-term study. The age of onset and other stuff were not known to you. There was
Yes.
no kind of correlated factors which you had evaluated, like there was any other kind of symptoms related to any mental health issues like OCD or something, repetitive behavior pattern, something
Yes.
like that. So that is
Yes.
that has to be incorporated. Also, a very limited population and a very limited period of time, and
Yes.
there should be some long, this thing, and related to the what you can say is follow-up studies and other stuff also is required.
Yes.
So yeah, so these are some of the things, and of course we are impressed with the efforts you have done to at least study a very novel symptom which is coming up a very in a very, what you can say, is a very high level. So we are also have started reading orthorexia nervosa as a term in some of the community magazines, I can see. Right? Not in a very particular medical magazines, but
in any
definitely.
science magazine.
Yes. Yeah, so congratulations to both of you, and I will open the house for discussion. Dr. Harmesh sir, you wanted to say something?
But Yash has done very well, and it's something new. We are learning, and as sir has mentioned, any research methodology is the main thing. So in this, there are few more things. Means we have to mention research and ethical committee approval in all such studies. Then we have to mention what was the mode of selection of cases. So there can be selection bias also. So we can't do in OPD or like that. We have to do in a community, or you have to find out how to select the cases, and then you can compare. And sample size are already mentioned. Then another thing is statistical analysis used, again important part, and so that there is no bias, and study should be generalizable, so that anyone else can repeat the study. And we have to use standardized tools. So that is the need of the our for such a study. It's very good, and I think till we have a definition for this, we can use something else like pattern of food habits, or like that, or because you are not sure about diagnosis of this problem. Thank you so much.
Right. So eating pattern, it's better to be, kind of a eating pattern, right, sir?
Yes.
Yeah. And Dr. Somsekhar, you wanted to say something? I think he's not. Anyone else who wants to ask questions?
Dr. Yash, can you stop sharing the screen?
Yeah, please.
Thank you.
So anyone else who have any questions? Shamikji, is there any question in the chat box?
There was just one question which was not answered. Any role of breath-actuated spacers helping in peer pressure or stigma, or spacers that are beneficial in school? And what was the role of teacher education? If Dr. Amit, would you want to respond to that?
Sure, sir.
Yeah.
breath actuated spacers are a very good thing, sir. They are more discreet, more easier to use, and even the drug delivery is very good as well. Especially this can be helpful in adolescents who are a bit more self-conscious and image conscious. If it is more discreet, maybe the compliance and the adherence may improve. And coming to the teachers part, sir, it's a very good question, especially the awareness amongst the teachers in early recognition of emergent symptoms, either it be cough or breathing difficulty or chest congestion, plays a huge role. So first, the teachers and the relevant school staff need to be educated and made aware of all the symptoms which may be possible in a asthma child. And second would be early intervention and management. They should be advised and make the child to use the inhaler immediately and make sure that the parent is also aware of the condition and they get an update immediately.
And schools would pick up exercise-induced symptoms also much more promptly, isn't it? Okay. So
Right.
that was the only question which was left unanswered.
Yeah, so if there is no other question, then we can, because Dr. MKC Nair has a lot of work today, and I'm so very thankful, sir. You could spare time to join us. Really, we are impressed with your dedication. And yeah, Dr. Swati wanted to say something.
Thank you, madam. When you call, I am at your service. Thank you.
Yes, sir. We are honored, truly honored, sir. Swati, आप कुछ कह रहे थे?
It was a very interesting session. I am really enlightened by on so many aspects. So very nice. Congratulations and thanks to sir and Sushma madam and all the seniors. Just wanted to remind everyone that AdolesCon is coming. And mostly the PGs, Dr. Amit, Dr. Yash, you and all your friends are most welcome here in Jaipur from 27th to 29th of November. And please spread the message. We would also want you to present your papers and cases and participate in the academics that we are holding here under Sushma Madam's guidance.
Yes,
Sure,
so
madam, they will
actually,
do.
when she has mentioned about AdolesCon, again and again we are declaring, and still I will take this opportunity to declare that through PG Pulse sessions, those 5 selected papers or studies will be given an opportunity to present their work in the National AdolesCon, which is going to be held at Jaipur, and encourage your friends also to participate in PG Pulse program, so that they can have a chance to present their work from the national platform and get guidance from a very, very legendary teacher like Dr. MKC Nair. So this is a opportunity, one of its kind. So this is what we are, and surely encourage all the colleges, Dr. Mamtaji and Dr. Somsekhar and Manmiji, all to participate wholeheartedly in Jaipur AdolesCon. So thank you so much. Thank you.
So I will, yes, I will take this opportunity of firstly thanking the 2 mentors, Dr. Mamta Mohanty from SUM and the Institute of Medical Sciences, Bhubaneswar, and Dr. Somsekhar, who is from the MS Ramaiah Medical College. No words are enough to thank Dr. Amit and Dr. Yash. Dr. Amit, very, very well tackled, and especially the emphasis that you laid upon what are the adolescent specific aspects of management history. As your mentor very, very correctly, he touched upon each and every point and why a particular history needs to be taken so that you can come to a proper diagnosis. Thank you so much for enlightening us. Dr. Yash, I can assure you one thing. From all the 50 plus people who attended this particular session, they would not have heard of the word orthorexia nervosa before you have enlightened us. Yes, we need to fine tune our knowledge. We need to make it more scientific. And I hope you take all the suggested points constructively so that from you who has started this discussion, we get a proper paper at the National Adolescent Conference. Dr. Mamta Mohanty, please guide him, right? Okay, because we really are grateful to him for having brought up this topic. It is such an original work that he has done. We just need to fine tune him. And I'm sure by the time November comes, your study would have expanded. You would have done all the fine tuning, and you would have an excellent presentation at the National Adolescent Conference. Yes.
Necessary
Looking forward
things
to
will do.
Mumtaji. Yeah,
Thank you.
looking forward to.
Yes.
Okay. I would also like to thank Professor M.K.C. Nair, who, as usual, has had all the patience to go through each and every word that has been uttered, each and every word that has been said, and he always picks up very, very important points for all of us listening over here to learn. Thank you so very much, sir, for your continued enthusiasm and your guidance. I would like to thank each and every person. We do make an effort to reach out. It's so heartening to see so many faculty from medical colleges, PG students, and our HA members who have joined in this effort. It is your participation which gives us the encouragement to build upon this platform and to tell the world that this is a successful attempt. Thank you so very much. I will be failing in my duty if I do not display the certificates which we have prepared for our participants today. So allow me 1 second. So is my screen visible now?
Yes.
Yes. So I'll start. So please, a big round of applause to Dr. Yashwant Dayanidhi Godisi for his active participation as a PG presenter today. Hats off to you. And like we said, keep working on your project, fine tune it, and I'm sure you'll have a very original work about which you will be very proud of in the future.
Thank you.
No words are enough to thank Dr. Mamta Devi Mohanty for having, inculcated such an original piece of work. And here at PG Pearls, we will always say that we had heard about orthorexia nervosa on our platform. Thank you so much, ma'am.
Thank you, sir.
Amit, thank you so much once again for your very active participation as a presenter, a thoroughbred performance, I must say. You enumerated every point so beautifully, and thanks to your mentor, every point was elaborated so well. You were ready with all the answers. Thank you so much for this very adolescent-specific presentation and for a good revision of the GINA guidelines.
It was like revisiting the PG days.
Yes, thank you.
Thank you, Somsekhar.
And Dr. Somsekhar, we also have something for you as usual. You are a thorough guide, and you are so meticulous in your presentation, and you leave absolutely nothing untouched and unattended to. I'm sure a lot of us, somebody is speaking. Can you please be on mute?
That was a wonderful discussion once again, and a very successful session of PG Pulse.
So Dr. Somsekhar, thank you so very much for all your help in preparing today's session. And we are indeed very, very grateful to you. This little certificate is a small token of
Many
appreciation.
thanks for the opportunity. One of the unique opportunity, and sincere thanks from all of us.
Thank you. Thank you to
Social
everyone.
Thank you.
Thank you, sir.
Congratulations to all the presenters and the mentors. And we look forward to having more and more participations from your medical colleges, particularly
Yes,
so
sure.
in Jaipur, Adolescon, and more PG Pulse are coming up. So please make it possible to join for all the PG Pulse and encourage others to join us. Thank you so much. From bottom of the heart.
Before I end,
Welcome,
can I please
Thank
call
you.
upon
Thank you, Somsekhar.
can I please call upon Dr. Sameer Shah to give the vote of thanks? He's responsible for all these wonderful flyers and for having this on YouTube and for archiving all that we do. Dr. Shah, if you're there.
Yeah, he's there.
Yes,
He's
yeah,
always
he's
there.
there.
Very, very sincere, dedicated person.
Yes.
Beyond
Dr.
words.
Shah, please, your few words and we'll end.
First of all, my sincere thanks to our grand expert, Dr. M.K.C. Nair sir, for the enlightening us with this such important and very untouched topic. Two topics that are totally different. One is known for very well, That is about the asthma, and the second is the orthorexia nervosa, which is the very new terminology for the many of the us. So sincerely thanks sir for the enlightening us. My sincere thanks to the both the mentors who are mentoring such excellently that ultimately their PG presenter presented such a nicely. So my sincere thanks to all the team efforts what they had prepared, making that preparation and presentation. Of course, my sincere thanks to our own chairperson and the secretary who are taking good task along with our Dr. Manmeet Sodhi madam, the program in charge who are taking the task to making this possible every monthly. Last but not the least, is thanks to each and every participant who are remaining present as a uh, throughout the whole program and understanding what are the different aspects of these unique topics and encouraging us being the organizers to become the making a more such type of the topics and program available for you all. So thanks a lot once again, and we can conclude the talk. Thank you.
Thank
Thank
you.
you.
And have
Thank
a
you.
good day. Thank you.
So see
Have a-
you again next month on the third Thursday, same sharp at 3 p.m. Thank you.
Yes, thank you so much.
Thank you.
Thank you, sir.